Hi.
Hi.
Hi, Dr. Ishita and Dr. Vitrag.
Hello, sir.
Hi. Hi. Hope you're doing fine.
So
Yes.
far, so
Yeah.
good.
So today, I think we shall discuss something related to diabetes complicating pregnancy. So this is something which we all find to be a very big problem, a very common problem,
Yes, sir.
and something which we are very much concerned about. So shall we discuss a few personal
absolutely.
experience,
Yes.
personal experiences with respect to similar cases?
Sure. So, what was your most unique experience, one would say, in treating a GDM?
Um, the first case which always comes to my mind is a patient with type 1 diabetes who got pregnant. So this patient came to me after marriage for glycemic control, and the first advice I gave to her was that you need to have your diabetes controlled in a better way. Her HbA1c was around 9 or 9.5. You need to have you need to get your blood sugars controlled before getting pregnant. But as often happens, the patient got pregnant immediately after in the next couple of weeks. So again, that was the first dilemma. The patient was on a premix insulin, 2 times insulin, and it was very difficult to convince her to shift to the conventional or the classical way of managing with basal bolus insulin.
Yes.
And she continued with the premix insulin. It was very difficult to get her blood sugar controlled. It had a seesaw pattern. And one day, suddenly, the patient got a urinary tract infection and got admitted with a DKA. And again, that was very much a tense situation. And at the time in the hospital, we managed the patient with an insulin infusion. Somehow, we controlled the sugars, and luckily, we got some time to discuss with the patient regarding the importance of glycemic control, regarding the need to take multiple injections to control blood sugar, especially in a type 1 diabetes. And we were able to convince the patient to shift to a basal bolus with 3 injections with the meals and 1 injection at bedtime. And this happened during the 3rd month or 4th month, if I remember exactly. And during the rest of the period of pregnancy, we were able to control the patient to a reasonably good level. It was not to the recommended targets as by the guidelines, but it was a reasonably good control. And at the end of 9 months, the patient had a normal delivery. It was a full-term normal delivery. That was the beauty of that.
Yeah.
And surprisingly, no perinatal complications or even the peripartum complications.
Wow.
And that's something which brought about a lot of tension, and at the end, it brought about a lot of joy.
I think it's very much important to react from the start.
Yes.
Yes. And
the complication part.
the lesson I learned is that we have to talk to the patient. I might not have spent enough time with the patient initially, but luckily or unluckily, the hospitalization gave me enough time to talk to that patient. She's still coming to me, and her kid is around 4 or 5 years now. She's still doing well. Both are doing well.
Wonderful.
So that's my story.
Ishita, you have any interesting cases like
Actually, not. It's actually a very joyful story, like Sir described. There was this patient. She was not conceiving, and she was a type 2. And so generally we explain, okay, fine. If you conceive, you have to shift to an insulin and everything, and then the pandemic hit. And luckily, her husband travels for work, but during the pandemic, he was here only in the city. So they conceived, and through the entire pandemic, and then it was like a COVID baby, and we were able to control her blood sugar levels very well. And of course, the shift was a little difficult because initially you don't get the control that you want, but luckily throughout the pregnancy, the blood sugars were well under control and healthy baby now.
Yeah, and
So yeah.
so I just want to one case that one of my patients who is a wife of my friend who himself is a doctor. Her wife's weight is around 48, 49. They conceived almost 5 months of pregnancy, and in a routine checkup they did a GPT. In glucose tolerance test, the blood sugar came around 160, 162. Looking at her weight, body structure, we can't even imagine that she may develop glucose tolerance test with higher sugar levels.
Yeah.
So I was surprised how she will get this. We know that in pregnancy, even those who have absolutely no symptoms, who are not even who do not have predisposing factors or who do not have any family history, even though those patients may develop diabetes during the pregnancy. So I think it is very much important to screen before pregnancy, regularly during the pregnancy.
Yeah, we need universal
Yes.
screening.
If we don't screen, we never come to know that she is having high blood sugar levels. And being a doctor, my friend immediately convinced that she will require insulin. We have started insulin from the start, basal bolus throughout, and they were very much well in control, and she is doing very well now. So I think most of the times we think that even if the symptoms are there, only then we should screen. But I think it should be a routine thing that, like in pregnancy, we check our blood pressure, we do the routine pregnancy takes sonography. Likewise, the blood sugar should be checked thoroughly in each patient.
Absolutely. I
Yes.
think that's very essential. The moment a person realizes, a
Yes,
female realizes
exactly.
they're pregnant,
Yeah.
should go for a blood sugar
And
test.
just
definitely.
like that, we should we can avoid the hospital emergency.
Yes, definitely.
In pregnancy,
Yeah.
with the patients with high blood sugar and going with the decay, that may develop any complication for the baby also.
Yeah.
Baby also. Yeah.
Yeah, I think we have a good message from these three stories. Like we have to diagnose diabetes during pregnancy very early. We have to ensure proper checkups, regular checkups, both with respect to the baby and the mother. And also we have to convince the patient for the right treatment, whether it's insulin or just lifestyle or it's metformin. We have to convince the patient regarding the importance of good glycemic control during pregnancy.
And the insulin, I guess, remains the best treatment for any patients during the pregnancy. Everyone should understand the insulin is not a bad thing. It is the best thing actually. That will prevent you from complications.
Yes.
Any
And-
comments from you, Ishita?
So basically, even if a patient gets diagnosed after they conceive, or they are diabetic beforehand on tablets, so we can make the shift well in advance when they are planning a baby, and of course we can ensure a good blood sugar level control throughout.